Good evening. Welcome to another evening of the Summer Health Series. I'm glad to see everyone who's out here and then those who are out on video land. Welcome to our second evening of the 2025 Summer Health Series. And so we have another great topic for you tonight, especially for the men and the people who support our men, particularly our topic. We'll get into that a little bit later. We want to also give honor to our leader and shepherd, Dr. Logan, and thank him and Sister Logan as well for the opportunity to share our gifts and help edify the body. So with that, we're going to start off in prayer. So if you can bow your heads. Lord, we thank you for this day. We thank you for your goodness. We thank you for your mercy, God. We thank you for another day, God. We thank you for the opportunity, God, to educate ourselves about this temple, God, that you have given us on loan. God, we thank you for this Summer Health Series. We thank you for this opportunity, God. We thank you for the topic that will be discussed on this evening. God, we just pray for the speakers. We pray for the speaker who is on their way, that you'll give them safe passage, Lord. And we just pray that all that is shared tonight will be helpful and beneficial to all those who hear it. And we'll be careful to give you the glory, the honor, and the praise. For in your Son, Jesus' name, we pray. Amen.
Amen. Thank you, Dr. Pullen. So as mentioned before, this is our, I think we said 19th year.
This is 19.
Yeah, so our topic is on cultivating excellence, nurturing resilience and well-being. And this evening you're going to hear some information that is really important for us to share. Every night has pretty much been important. If you weren't here last week, we talked about from the cradle, and we don't say grave, but to the older age individuals, and we focused on different aspects of our life through our ages. And one of the things I want to encourage you, Dr. Pullins did a phenomenal job with Dr. Kruger, is that if you missed it, please go back in video land. We have it in YouTube, Facebook, and also on our website. Please look at some of the things that were shared during that moment. But tonight I'm excited. As I mentioned before, we're going to be talking about prostate and different issues as it relates to men and prostate concerns. I will share with you, Dr. Pullins, I know you're going to be speaking, and then later our speaker is going to come in. But about a month ago, I did a project in the community in the East Valley, and it was a phenomenal project. It was called Macho, Men Against Prostate Cancer Helping Others. And that was a well-received program. We were able to have some of your colleagues from Mayo there. We had some community reps, and we also had over 60 men present. 30 plus were screened. And I can tell you the outcome, if you've missed it, it's in the Informant. 2 weeks ago, it was placed in Informant because it was a phenomenal project. So again, I am looking forward to hearing this message tonight. Dr. Pullins is going to start us off by talking about the pathological areas of prostate and how it impacts men. And then later, we're going to be joined by Dr. Humphreys, who's going to come in and enlighten us on some of the information that he has added to what's going to be shared, and also the work he's doing at Mayo. So without further ado, I'm going to hand it over to Dr. Pullins.
Thank you, Dr. Allen. So the Bible says, be also ready. And this is one of those moments where you have to roll with the punches. Our speaker had the wrong address, and he was over in the East Valley. So, but I'm good. I can step in for him until he gets here, and that's what we're going to do. So I'm going to first start. If you can bring out a bio about our speaker, and I'll start there. So, and if you can have my slides up front, thank you. So this is Dr. Mitch Humphrey. So he is the chair of urology at Mayo Clinic, Arizona, and he holds dual appointments there. He focuses mostly on oncology, cancer, genital urinary issues, as well as stones, enlarged prostates. And he is considered an international specialist in what he does. And so definitely someone that can shed some light more than even I could when it comes to the prostate and things of the urological system. He's published over 200 peer-reviewed manuscripts, and believe me, that takes a lot of time and effort to do that. He also sits as a journal editor and reviewer for several international urology journals. And, most of all, like me, even though he has climbed high up in Mayo Clinic, he is very involved in community work. And so that's why we share a bond there. All right, we can go to. So we're going to talk about prostate matters, what every man and family should know. And this is a very important topic because particularly in the African American community, we see higher levels of prostate cancer. And in particular, we tend to have it found at more advanced stages. So when you look at all comers, about 1 in 8 men in the United States will have prostate cancer sometime in their lifespan. So it is fairly prevalent, and we've seen an increase in prostate cancer. And what's interesting about that is that when you look at the associations that decide on how often certain screenings should be done, if anything, they've become more conservative and been less aggressive in having screenings for prostate. So you would think with that that there would be maybe an issue of seeing less or more prostate cancers, but despite that, we're seeing more of it, and we think it has to do with obviously, being inactive. We know that when you have more adipose tissue, which is fat tissue, it causes more issues with people with prostate cancers, genetic issues, environmental things are in our diet. All these things are kind of leading to increases in prostate cancer in general. So this is what Dr. Humphreys wanted to make sure we talk about, and I'll kind of go through his slides. So what is the prostate? We're talking about prostate cancer. Let's say what it actually is, and then we'll go through some of these other topics on tonight. So what is the prostate gland? So kind of knowing where it is important because it makes a lot of sense, particularly when your prostate enlarges. Why does it affect your urination? Well, if you look at that prostate gland, it's sitting right below your bladder. And so your bladder has to empty through the prostate to get the urine out. And so you can imagine if your prostate is starting to enlarge, you're going to have trouble emptying your bladder. And so if that's enlarging the bladder cannot fully empty the urine, then you're going to not completely empty your urine. You'll be having to go multiple times. Obviously, it's going to affect your stream. So the more resistance your bladder has to overcome, you're going to have issues with the urinary stream. And so the other thing is if you get prostate cancer in that area, there's a lot of blood flow. There's a lot of nerves that are in that area. So you can see if they're going in to try to have to remove the prostate or do any treatment, you have to be very careful because you can have some issues. And that's why sometimes after prostate cancer treatments, you have issues like erectile dysfunction because those nerves that are responsible for that go through that area. Also because it's close to the bladder, a lot of urinary leakage can happen because, again, that the closeness to the muscles that control emptying the bladder. So let's keep going. And just let me go back real quick. And so what does the prostate do? That last step is, so the enzymes, they say they're necessary for conception. So when the testes are making sperm, the prostate actually secretes something that kind of keeps those sperm cells alive long enough to get to an egg for insemination. So that's the purpose of the prostate gland. All right. I'm going to stop there first to make sure there's no questions. Do we understand what the prostate gland is, where it is, and what it does? All right. So on this is more the anatomy of the prostate. And so when urologists are looking at the prostate gland, particularly when it comes to cancer, they kind of break it up into quadrants. And what this particular slide is just showing is that these are the different quadrants that they break up the prostate in. And so the periphery area, which is D, which is, I think you can see that if you can't see it on the TV screens, that's where the majority of cancers are found. And that's a good thing because that kind of helps us when we're doing a digital rectal exam. D is the part that we're feeling. Okay, so if you have a prostate cancer in the D section, those are easier to catch versus if you see something that's deeper down, obviously our fingers can't feel through all that prostate tissue, so we may not be able to see that. And then he just kind of breaks down the different zones and what actually what's going on in those particular areas. Again, as I was saying before, the reason why it's difficult when you're treating prostate cancer because there's so many nerves and blood vessels that are involved in that particular area of the body. And so this is obviously technical because this is kind of giving you the very detailed anatomy of that area, but it just kind of gives you an idea of what they have to deal with when they're treating the prostate. And here again, the urethral sphincter, that's the muscle that's under our control to let urine out. So when you get this signal, your bladder stretches, it sends a signal through your spinal cord to your brain that you need to relieve your bladder. That sphincter is actually under your voluntary control, meaning you have the control to say, well, yep, we're going to let you out, or no, not yet. And so again, when you're dealing with that treatment, if you don't do it smoothly and you affect those nerves, you can affect that particular sphincter and then have issues with that male after treatment. So this is what I was talking about early of the prostate and an enlarged prostate. We call it BPH, or benign prostatic hypertrophy or hyperplasia. And so as men get older, all of our prostates get larger at various stages. Some guys have it sooner than others, and some guys never have the issue. But as I was saying before, when you look at on the right where it says BPH, you can see again how that prostate is enlarged, is now starting to push in on the bladder, and the bladder has a lot of trouble trying to actually eliminate the urine that's in it. LUTS means lower urinary tract symptoms or syndrome. That's what that stands for. So there are various types of symptoms of BPH. There is something called static, and that's because the physical obstruction of the prostate is the issue. And then dynamic component just means that just like in the heart, if you have high blood pressure, and when the ventricle is pressing against high pressures over a period of time, the muscle, the wall actually gets thickened. And just like in the heart, too much muscle is a bad thing. Same thing in prostate. If the prostate gets too large, it affects its ability to empty and function correctly. So that's what that is. And Dr. Humphreys, when he can talk about that, but he actually does a treatment called HOLIP, which is like a laser type of treatment to actually reduce the mass of the prostate gland so that then there's no longer that obstruction of the bladder emptying. There are some medications that I'm not sure if his slide's going to talk about, but there's also some medications that are used before we actually consider doing this type of treatment, which is a surgical treatment called Flomax. Has anyone heard of that? Flomax. So Flomax is like a muscle relaxer for the prostate, meaning you take it, it causes the muscles of the prostate gland to relax so that there's less resistance that the bladder has to overcome. Any questions about the enlarged prostate? I will say this, that just because you have enlarged prostate, there's not a direct correlation to prostate cancer, meaning that just because you have a large prostate doesn't mean that you are going to have an issue with prostate cancer. Yes, Reggie. And
thank you, Dr. Allen. Dr. Pullins, you had mentioned a few minutes earlier that the prostate releases a chemical that's essential basically for conception. Mm-hmm. If you were a male still in, we'll call it birthing years, producing years, and you were to have your prostate removed, does that impact your ability to father children at all?
Well, I can't think of a real life situation where a male of childbearing age would ever have his prostate removed to begin with. So I don't think that would ever happen. Yeah, that's probably the best way I can answer that. It may affect it somewhat, but I would just say that usually traditionally wouldn't be something you would see. All right, let's go on to prostate cancer. So as I was saying, it's 1 in 8 men in the United States. Obviously, it's in the prostate gland, and it is one of the most common cancers. It develops slowly, so there's a saying in medicine that you have more chance of dying with prostate cancer than dying of prostate cancer, and that is true because it's a common cancer, but many times it's a slow growing, and so you'll die of something else before it becomes an issue for you. Yep, often silent. Like I said, no symptoms unless the mass is in an area that's causing obstruction of the bladder. Then maybe that may be an issue there. So when you have any type of cancers, there's different families of cancers, and one is called adenocarcinoma. That's just a family of cancers, and that's the most common type that you will find in prostate cancer, about 95%. And we talked about the function of the prostate gland. It secretes this solution. So there's glands in the prostate gland, and these glands is where the prostate cancer originates from, those type of cells. The more aggressive forms is called small cell, and that's fairly rare. You said the adenocarcinoma is 95%, but the small cell is rare, but it is very aggressive. And so if you don't catch this early, most times by the time we find it's metastatic, meaning it's moved to the bones, liver, and maybe lungs. And then there's another class called neuroendocrine. So that just means that those particular cells are coming from a neurological source, and endocrine means hormone producing type cells. And again, they also don't respond well to hormone therapy, and they spread fairly fast. So this is just some data that he has included in his slide, just to kind of show you where prostate cancer stands as of 2024, and this was put out by the American Cancer Society, looking at the leading causes of new cancers in males. And so as you see, prostate cancer is number 1 for new cancers. When it comes to deaths from cancer, prostate is number 2 for the death rate, but definitely prostate. And you see right under that is lung, and lung is been up there. I think if you look at the females, it's about the same, far as it's high up on the list for deaths. Yes.
So, Dr. Pullins, other than the increase of prostate cancer, do we see any increase in ethnicity or age? Are you seeing it more in younger people, and are you seeing it more in African Americans?
Yeah, and Doctor, I'll probably defer to Dr. Humphrey as far as if we're seeing a certain age group, but I'll just say in general, the numbers overall have increased. African Americans, we have more, again, a death rate from prostate cancer, but again, that's a lot of times because by the time we catch it, it's more advanced, and so that's where the death rate comes. But overall, all comers, there's been an increase in prostate cancer, just like it's been an increase in colon cancer. And I talked about that last week, that probably about 3 years ago, colon cancer screening went from age 50 down to 45 because we were seeing an increased level. And I foresee that it'll probably go down to 40 because we're seeing younger and younger people even with colon cancer. And he has something in here. So here it goes. So this is starting in 2019, and this is going through 2023. And so in that 4-year window, there's been a 65% increase in prostate cancers. I'm not sure if some of that is also because people are getting more education like this, and the health literacy around prostate cancer is increasing, so more people are actually going in to get checked. Before, when I was coming out of medical school, we always did a PSA, which is a blood test, and we also did a digital rectal exam. So we're not really doing a digital rectal exam as much as we used to do in the past. We kind of rely more on the PSA. And the reason behind that is because the digital rectal exam is very user dependent, meaning how skilled is the examiner that's doing it. So some people may feel something that's not there. And now, you're putting somebody have to go additional testing, maybe a biopsy that they don't need. And so some of the screening techniques has gotten more fine-tuned. So most times we can get away with just doing a blood test. And I think guys in general are more open just to getting a blood test than doing a prostate exam. And so I don't really do prostate exams anymore unless, I think they have prostatitis, which is like an inflamed prostate, or they're having urinary symptoms. I think that it may be because of enlarged prostate. Then I need to know, is it enlarged prostate or what we're dealing with? So there was certain situations, but I don't do all comers anymore like we did in the past. So, and I'm not sure if he had this to be a quiz, but I'm going to go forth. So which are not risk factors for prostate cancer? Well, he gave you the answers for that. And I'm not sure. He has obesity, smoking, inflammation. I'm going to wait for him to get here because I'm not sure. Because I would think that some of those in red would be. So maybe that's something that he can shed light on. So we'll come back to that slide. So prostate specific antigen. So that's the lab test that I was telling you. So most people know or heard that test. Is there anybody hasn't heard of a PSA before, or prostate specific antigen? Okay, so very common. So this is usually the test that we use to screen for prostate cancer screening. And so it was first discovered in semen way back in 1966. And then they found it was also in blood, as you see. And so this is something we usually do annually. And so there is a range that is normal. And then we also look at if there's trending. So a guy can have a normal PSA level, but if it's jumping more than, we say, 0.75 in 1 year, that's another reason why we may say, okay, we need to follow you closely, because although your PSA is normal, the velocity of it moving is too quickly, and then we may find that there's an issue. Dr. Humphrey's in the house. So you have been introduced. You are ready to go.
Well, first of all, I apologize. And second of all, thank you so much for allowing me to be here and spend an evening with you. And I'm happy to look forward to taking as many questions as possible, but sharing some information. And fortunately, Dr. Pullens, brilliant. He handles all of medicine. I'm a simple plumber. From here to here, that's what I do. So I can focus on my particular knowledge. So I'm just glad to be here with you tonight. So.
Well, we'll just pick up where I left off.
Sure.
There was a question. Oh, I'm going to go back because there was a slide that you had about risk factor for prostate cancer. And I was a little bit confused because when I was reading some of those, I was like, well, what do you mean by that? So if you can maybe start there.
So yeah, let's talk about the risk factors for prostate cancer. So what we know about prostate cancer is it's the most common solid organ malignancy in men. It's the second most common cause of death, cancer death, in men. So it's very prevalent. The thing about prostate cancer is it tends to be slow growing. So most prostate cancers you have time with. And when we talk about the risk factors, age is a risk factor. It's rare in men under 40. We know that race is a risk factor. It's more common in certain ethnicities. So in black men, it's 70% more common than in other men. It's twice as likely to result in mortality in black men. So it's really important to think about prostate cancer. Nationality, it tends to be more common in North Americans, Northern Europeans, also African American men and men from the Caribbean. It's more common in those populations, less common in Asian populations. Family history is a significant risk factor. So if you have a relative, first degree relative, which means brother, father, uncle, somebody in the first degree, you are twice as likely to have prostate cancer. And it's more important if you have a brother or a sibling that has prostate cancer, it's more common that you will get prostate cancer. And if you have two first-degree relatives that have prostate cancer, it's 5 to 10 times more likely that you will get prostate cancer. It's also carried in genes. So about 10% of all prostate cancer is inherited. And so a lot of times you may hear us say, prostate cancer, we think about breast cancer, and we think about the BRCA genes and being carrier for those genes for breast cancer. Those same genes that cause breast cancer also are implicated in prostate cancer. So it's important for men, if breast cancer runs in family, also to be thinking about prostate cancer. We talk about diet being a risk factor. Unfortunately, good things to eat can cause prostate cancer. Red meats, high fatty diets, things like that are more associated with prostate cancer. Obesity is not a risk factor for prostate cancer. Smoking is not a risk factor for prostate cancer, although it is for lung cancer. In work exposure, the only positive study that's been done to date has been in firefighters exposed to certain combustible chemicals. They've had an increase in risk of prostate cancer. There is some risk in Agent Orange for those from the Vietnam era that have been linked to prostate cancer as well. The question of inflammation, some data says yes, when you get multiple prostate infections, you have a higher likelihood of prostate cancer. Other studies say no, so I'd say the jury's still out in terms of that as a risk factor. STDs do not increase your risk of prostate cancer. And there was a time where if men got a vasectomy, some literature reported that there was an increased risk of prostate cancer. Turns out that is not true. That's been disproven. So there's no link with vasectomy and prostate cancer.
Perfect. Thank you. See, that's why he's here. So we were going into the PSA test. So can you tell us what PSA and does it actually help us find prostate cancer early?
So the advantage of PSA is a lot of times when men have prostate cancer, you won't have any symptoms. You feel fine, you're doing well, you're not going to notice anything. You may not have other signs of cancer like blood in the urine, pain, or any of those things. So a lot of times PSA is a blood marker because PSA is actually a normal enzyme that's used for the liquefaction of semen to help us have children. Sometimes we want children, sometimes we don't want children, it just depends. So it's a normal enzyme, but when you have prostate cancer, those cells make more of that PSA, and it disrupts the membranes between the prostate and your circulation, so a lot of times we find that elevated PSA in the blood. And so using that as a blood test helps us identify prostate cancer. The problem is PSA does not mean you have prostate cancer. You can have an elevated PSA because of inflammation, infection, recent sexual activity will cause your serum blood PSA to go up, or it could be cancer. But we won't even know to look for cancer unless we have that PSA test. So it's shown to be a very effective screening test to help us detect men at risk for prostate cancer. And on average, it will detect prostate cancer before it's clinically visible. In other words, you can find prostate cancer in the early curable stages with a PSA screen, which before you couldn't. So if you go back before PSA in the 1960s and early 1970s, most men with prostate cancer presented when the disease was already spread to the bones, you wouldn't cure, and that it would result in death. With PSA, we can find disease 6 to 13 years before clinical presentation, which means we have a chance to cure that disease and prevent the spread of the disease for metastasis to other organs or other parts of the body.
So, over the last 10 years at least, there's been a lot of controversy around prostate cancer screening, particularly PSA, digital rectal exams. And I think even between my field of primary care and urological societies, there's a lot of different opinions on that. What is that kind of all about?
Yep. So the controversy with PSA screening is the controversy isn't so much about PSA, but the problem is that PSA is nonspecific. Like I said, the ideal screening test would be specific. You would find the cancer. You wouldn't have false positives. It would be low cost and it would have low morbidity or side effects associated with it. So a simple PSA blood test itself is not a controversy. But the problem is there's so many other things that can cause an elevated PSA. When you had an elevated PSA, it could result in other tests that needed to be done, things like biopsy. There's risk of infection. There's risk of bleeding. And so what the big proponents that argued against PSA screening said, well, if you look at the population, yes, 1 in 7 men are going to get prostate cancer, but it's such a slow growing cancer, not many men are going to die from it. And so we're willing to accept the low death rate from prostate cancer. That really is good from a population, from a country, from an economic standpoint. But if you're that person with prostate cancer, it's a terrible policy, right? So if you're the individual, it's a terrible policy. And it's one of these diseases that if you intervene early, you can live a full life and be cured. So where the real controversy with PSA comes in today, and the way that we should think about it is, how do we use PSA to be smart about screening? Maybe you don't need a PSA every year. Maybe it needs to be every few years. And then when you have an elevated PSA, what do we do about that? So it used to be when you had an elevated PSA, what we could do is we would biopsy your prostate, and we'd randomly biopsy the prostate we just sample it to hope that there was no cancer there. That was successful in finding about 20 to 30% of prostate cancers. Now, in 2025, we have advanced imaging, things like MRIs to look at the prostate. So if you have an elevated PSA, you can get an MRI. That MRI will only miss significant prostate cancer 4 to 6% of the time. So it's pretty accurate. And when it finds prostate cancer, then you can be smart about your biopsy to biopsy the lesion that you're worried about instead of just randomly sampling the prostate and hoping you hit it. So it becomes a lot more specific to you in finding your disease and classifying that disease. So the concepts around PSA have changed a lot. It is still the broadest, simplest tool we have to look at men for identifying who's at risk for prostate cancer. There used to be this concept based on your age, what your PSA should be. That's a historical concept. Really, the most important thing is how the PSA changes over time from year to year. That's the velocity that Dr. Pullins was talking about. We also know what we should be thinking about in terms of PSA density. If a man has BPH and a large prostate, we then can look and calculate what the PSA is for that large prostate. And if it's over a certain level, you're at a certain risk. But in my mind, and this slide will come up later, the most important PSA is probably that first PSA you get in your 40s and 50s. Why? Because we know that that PSA is predictive of your lifetime risk of getting prostate cancer. Doesn't mean you have prostate cancer, but say your PSA in your 40s is 0.6, the chance of you dying from prostate cancer is so low, you may not need another PSA check for 5 years. Where if your PSA in your 40s is 1.2, doesn't mean you have prostate cancer now, but your risk of developing prostate cancer in life is much higher, so you have to watch a lot closer and get the screening on an annual basis instead of every 5 years. And so the controversy, the reason there's controversy between different societies on what you should and shouldn't get isn't because of the PSA, but it's what follows after that PSA. And so in my mind, in 2025, when we have advanced imaging, things like MRI, we can be a lot smarter about it. And that doesn't even get into all the controversy around the different types of PSA.
There's a question before
Yes.
we ask that question. So before you came in, I showed the slide that you showed that over the last 4 years, how there was a 65% increase in the incidence of prostate cancer. So I think that's interesting because I think that as the screening has become overall more conservative than aggressive, you would expect that there still wouldn't be necessary increase because you would have maybe less people getting screened, but yet there's an increase in incidence. So I'm not sure what are all the factors that you think are causing that increase?
So when you look at that data, what happened is the United States Preventive Task Force in 2012 came out with a recommendation that men should no longer be screened for prostate cancer. This was under Obama. And he said, you know what? I'm still going to get my PSA checked. And then when men were dying, what we saw during that time we weren't screening for PSA, men were presenting with metastatic disease when they weren't curable. They had much worse quality of life. And then they were hospitalized with the side effects of prostate cancer, things that we hadn't seen in 30 years since we introduced PSA screening. Then the task force came back and said, okay, we're going to amend our recommendation and say we should be screening men between 55 and 65 that have at least 10 years of life ahead of them, but it should be a shared decision discussion with the patient and their provider to think, okay, if the PSA is elevated, what's our next step? Is it going to be a biopsy? Is it going to be an MRI? And okay, if we find prostate cancer, are we going to treat it or not treat it? The thing about prostate cancer is it's a very diverse disease. Not all prostate cancer is the same. I had one professor explain it to me that said, think of prostate cancer like a snake. Some prostate cancer is low grade, low malignant potential. It's like a gardener snake. It's nice to have around. It's not going to hurt you. It will be there. Learn to make friends with it. Where other prostate cancer can be like a rattlesnake. It is the one that is going to bite you. It's going to kill you and end your life. The trick isn't identifying the prostate cancer, but it's in identifying which cancers are lethal and life-threatening, and which ones are low, slow grade, and slow growing. I think part of the PSA controversy that we see today is because early on, when we heard the word cancer, we would automatically treat, and so we over-treated prostate cancer. Now, we've gotten a lot smarter about which prostate cancers to treat, which ones are life-threatening, and what are the best ways to treat them to decrease the impact on men's quality of life and lifestyle.
Yes, Elder Baker.
Dr. Humphreys and Dr. Williams, thank you for being here. Yeah, my question is a few slides earlier. We talked about the death rate in African American men being twice as likely from prostate cancer. I wanted to kind of have you explore that. Is it because the cancer is metastatic or is it other comorbidities? I'm just trying to see what is that 2 times based on.
So there's several reasons for that. So one of the reasons for that is if you look at the biology of the disease, prostate cancer in black men tends to be in younger men, and it tends to be a more aggressive subtype of cancer. When you look at that, there tends to be some association with the genetic linkage of that in terms of the testosterone receptors, and there's alterations that feeds the prostate cancer more in black men. Black men are less likely to seek medical attention. They're less likely to get screening. They're less likely to have access to quality health care where they're getting the screening and the PSA testing. All of that means is that when they come in and they present with that first PSA or with that prostate cancer, it's a later disease and it's a more aggressive disease. And so thus, the data that we have right now, we have a death rate of twice, but one of the big problems is the research and the data done for black men is much less than in other groups. Nobody's doing the research because people are unwilling to get involved in the research studies and things like that. So that's a weakness in the healthcare field for sure.
Yeah, thank you for that. And a follow-up question with that is based on understanding that it presents in black males earlier, are there different recommendations for when black men should have a PSA?
Absolutely. And so if you look at the recommendations, most of the screening recommendations will say screen men between 55 and 65. My recommendation is for black men, they should be screened from 40 and older. And if they've got a first-degree relative, it's really important to get that first PSA when they're 40. If that first PSA when they're 40 is 0.6, that's very reassuring. Doesn't mean you don't ever need screened again, but that means that there's no cancer lurking around the corner. Because that first PSA is so important because when you're 40, you don't have a lot of BPH. So the PSA is reflective of the parts of the prostate where cancer grows, so it's much more specific to the disease. And so it's a much more powerful predictive test in your 40s than later in life when you've got BPH and enlarged prostate and you're getting up multiple times to pee at night, which is a personal problem as well, which can be fixed.
I have a quick question, and it's related to advocacy. You pointed out 2 things. One, your recommendation. So how do we advocate for African American men to get tested early? And then the second question you pointed out earlier, you stated that if you have a high PSA to get MRI, and you and I know that's a concern. Sometimes they're not doing those MRIs. So how do you advocate for African American men and their providers to get that MRI?
So I think there's two ways of going about that. First thing, in terms of advocacy to make sure men are getting checked, Black men and African American men, is to have the conversations, have open conversations. The healthcare system has not been real good. There's been problems in the healthcare system. So how do we increase the access to that system? I'm involved in some other groups, Man Up, where we do community screening, where we go out and we offer point of care PSA testing. We did it at the NCAA. And part of that is just having the conversation. A lot of times in a lot of families, people don't talk about their health. They don't talk about it with friends and relatives and things like that. And so having those conversations around the family table, around those units, and saying, Grandpa had prostate cancer, we need to be tuned into this. Or Aunt Bessie had breast cancer, and so we should be thinking about prostate cancer. And then when it comes to advocating for the MRI or for those next tests, that's just a matter of having a voice in the conversation to say, look, I had an elevated PSA. The next thing we need to do here is we need an MRI. This is standard in 2025, in my opinion.
Thank you.
So we spent some time on the PSA, and I think you had some more. This may be a little too technical unless there's something you wanted to add on to these.
I put some technical slides in here just for the point of knowing that PSA isn't the only test. So there's other ways of looking at PSA. There's a free to total PSA ratio to look at. There's something called a prostate health index or a PHI index. There's something called a 4K score. These are blood tests just like PSA, but they look at the PSA in different forms, and they come up with risk stratification to say, this PSA is elevated because of cancer, not because of inflammation, so you need to take that next step. So there are other things, but these are not good for screening. This would be, say somebody has an elevated PSA, and then they want to know more information before moving on to an MRI or a biopsy or something along those lines. These other biomarkers are designed for that purpose.
So speaking of advocacy, this is kind of why we try to help the health literacy around different topics. And so for these tests, the PHI, the K score, all these different things, for the men that are in our community or those who are listening or will watch this, having this information, if they're seeing urologists or thing, how would you give them counsel? Okay, hey, this may be a time you may want to ask your urologist to maybe look to the next step. We had a case, I remember someone asked me about, they had an elevated PSA and they were going to go straight for a biopsy with no MRI prostate. So my counsel was like, well, before you let them stick a needle in it, at least let them map it out. And that everybody doesn't have access to that kind of information, and so they may be getting testing that's unnecessary or not getting adequate testing. So how would you guide and counsel on that?
So several things on that. So these tests are, say a man has an elevated PSA and their provider says, you've got an elevated PSA, but let's watch it. And maybe you've got a relative that's had prostate cancer or something like that. And you're saying, I may not be so comfortable watching it. Let's do one of these other biomarker tests to see, is this elevated PSA real or is it not real? If it shows up on one of these tests that it's still elevated, that's a signal to do more. If it comes back as low, then that can be reassuring and say, okay, I agree with you. Let's check this again in 6 to 12 months. In terms of the imaging, I think imaging is so standard for several reasons. Because one, you get to see the prostate, you get to see if there's any suspicious lesions. Two, you get to see if that disease is confined to the prostate. It allows you to go past the biopsy. So if the biopsy comes back positive, what do the lymph nodes look like? Has the disease spread outside the prostate? Is the cancer still localized to the prostate? Because our goal is to find prostate cancer localized to the prostate, because then we can cure it. And so that MRI gives us information on the lesion, allows us to target for biopsy, allows us to stage for the disease to make sure it hasn't spread to the pelvic lymph nodes or anywhere else. And also it provides a baseline. So maybe they biopsy and there's no cancer today, but then 2 or 3 years down the road, you get an MRI and you can look to see, hey, here's this lesion on this MRI, and then you can pull up the other one and say, oh, we already biopsied that one. That's negative. We feel good about that. Or, ooh, this is a new lesion. This wasn't there 3 years ago. We need to do another biopsy because now this has popped up. Does that make sense?
It does. Any questions on that? I want to make sure everyone gets that. Okay. So we talked about the PSA. We talked about different types of PSAs. There's different scans and different biopsies. I wonder if you can maybe talk a little bit about that as well.
Yeah, so this is just a picture of what an MRI looks like. And so when you look at the MRI, there's several different sequences, but now what we can do in 2025, we couldn't do in 2010. MRI technology has gotten better, and we've learned so much that we're able to identify lesions. Now, an MRI is not perfect. So if an MRI was perfect, we wouldn't have to do anything else. We could do a PSA and an MRI and say, you've got prostate cancer. There are things that can look like prostate cancer on MRIs that are normal, but we grade the MRIs on levels of suspicion on something called a PIRAD scale. You don't have to worry about what PIRADS means or any of those things, but allows us to be thoughtful, then to do the biopsy to target it. This is what I was talking about earlier. Before, when we used to do biopsies, we'd put a probe in the rectum, we'd use a gun, and we'd sample the prostate. And we'd try and sample it enough so that we wouldn't miss prostate cancer. Most biopsies are 12 core biopsies, which means you take 12 SNPs, 27 to 40% cancer detection rate. The downside with transrectal biopsies is there's a risk of infection because that needle's passing in and out of the rectum. One of the things that patients always ask about, well, if you're biopsying the cancer and that needle comes out, are you giving a pathway for that cancer to spread? With prostate cancer, that's not the case. So a biopsy will not cause that cancer to spread. Other kinds of cancer, yes, but prostate cancer is a slow-growing malignancy, so it likes to stay there. What I like to think about it is, you think about there's a village, and if a village is very small, it likes to grow into a certain mass until certain members of that village decide to go out and set up villages in other places. Prostate cancer is that same way. It will not grow and spread to other places until later on in the disease, but there's never, after millions and millions of biopsies that have been done across the world, there's never been a reported incidence of a prostate cancer being sampled, and then because that needle spread. Contemporarily, what we do now for a biopsy is instead of putting a needle through the rectum and risking infection or some of those things, now we biopsy with the area between the scrotum and the rectum, and the biopsy goes straight into the prostate through that skin, so the risk of infection is way, way less. The risk of bleeding in the rectum or stool is way, way less, and it allows us to target certain parts of the prostate, because when you go from the rectum, you can get the bottom side of the prostate, but it's really hard to get the top side. You got to stick that needle all the way through there. And so this way you can numb up the skin between the perineum and the prostate, and you can target the entire prostate, and you can be very, very precise in how you do that.
Perfect. So once a man is diagnosed, how you talked about prostates being different type of snakes. How do the doctors figure out which type it is and whether it's serious or not?
So this is where it gets into a little bit more detail. And so when we look at prostate cancer, this is a slide that talks, and this is in the news now because we're just learning about PSMA PET scans to see how much of the prostate cancer has gone somewhere. So say we find prostate cancer on the biopsy, how do we know what parts of the body it's in? Prostate cancer, we talked about PSA. So there's something called a prostate-specific membrane antigen, which is just a protein on the top of prostate cancer cells. What these scans do is they go in and they attach to that protein, and so it just lights up where the prostate cancer is. So it allows us to tell where exactly in the body prostate cancer is. Hopefully, it's not in other places, but for men that have high-risk disease, have a really high PSA, those are the men who are worried about the prostate cancer going other places. And the PSMA scan is how we find it today. And that's kind of the contemporary things. There's different kinds of PSMA agents that are better for finding certain kinds of prostate cancer. But for right now, just think if you have high-risk disease on that biopsy, or if you've already been treated for prostate cancer and it comes back because now you have a detectable PSA, or if you really have high-risk disease with a really high elevated PSA, standard of care would be to get a PSMA PET scan to see where it is. because when we treat prostate cancer, if it's localized to the prostate, we think one way about treating just where the cancer is, but if it's spread to other parts of the body, we've got to think about treating the whole body. Because if you just treat the prostate cancer in the prostate, you're leaving prostate cancer cells in the other parts of the body that are untreated. So if it's localized, we can cure it. If it's gone to other places, we may not be able to cure it, but we can slow it down and we can increase somebody's longevity and their lifespan by treating those distant areas of the prostate. But we've got to think about whole body treatment rather than focal treatment just on the prostate itself. This is just a picture of what the 3D biopsies that we do today that mirror the MRI and fuse it with the ultrasound that allow us to do it transperineally. We use a system called UroNav. There's several different systems out there, but you can see that technology has really helped us find and identify the prostate cancer, which now in 25, we're now thinking about, well, gee, instead of treating the whole prostate, maybe we just treat the one part of the prostate that has prostate cancer. Same thing in breast cancer. Sometimes we just treat the mass in breast cancer. Sometimes we have to treat all of the breast tissue. It depends on the disease itself and what it looks like. This is a picture of doing that transperineal biopsy where we're no longer using a needle to go through the rectum, but to go through the skin between the scrotum and the rectum. I think if you go to the next slide, this talks about how we think about prostate cancer. And what we do is when we take that biopsy and we look at it under the microscope, we grade it on a scale of 1 to 5, with 1 being cells the closest to normal and 5 being very abnormal where they forget to be their prostate cancer. Really, Gleason scores 1 and 2 are historical. We really don't see that anymore, but if you think about it in the simplest terms, when it's Gleason score 3, that's low grade. When it's Gleason score 4, that's intermediate. When it's Gleason score 5, it's high grade. And what we do is when we look at that slide under the microscope, we see the most common pattern of abnormality, and we give that a score. And then we see the second most common pattern of abnormality and give that a score. So you may hear people talk about Gleason 3+3. That's low-grade disease. We don't worry about Gleason 3+3. You'll hear people talk about 3+4 versus 4+3. That means the primary pattern in one patient is 3, the low grade, whereas if the first number is a 4, the primary pattern in that patient is a 4. The new system tries to simplify this even further in saying grade group 1, 2, 3, 4, and 5. With the grade 1s are the cancers we don't worry about. Grade group 4 and 5 are the ones that we really worry about. Grade group 3, we have to think about intervention, but with grade group 2 and 1, we may be able to just watch those cancers and see if they change over time where we need to do intervention. And so that's looking at the cells of the cancer, but we also stage the cancer on how it's spread. Is that cancer localized to the prostate? And you'll hear people talk about TNM. It stands for tumor, the primary tumor. N for the lymph nodes. As it go to the lymph nodes, our body has millions of lymph nodes and they're almost like little surveillance stations. So if cancer goes somewhere, it typically goes to those lymph nodes first before spreading to other places. And then the M stands for metastasis, and has that cancer gone to other parts of your body, like your bone, your lung, your liver, other places like that. So when we talk about the T stage, that means, is it organ confined? T1 is a historical concept based on whether you get a BPH surgery. T2 means the cancer is confined to the prostate. T3 means it's starting to grow outside the prostate, and we got to worry about it. That needs treatment sooner rather than later. T4 means it's already spread outside of the prostate. Maybe it's spread into the bladder, it's spread into the musculature, or something like that. T4 is kind of a bad deal. If it involves the lymph nodes, that just means that we have to start thinking about the whole body, because once the cancer gets to the lymph nodes, that means it has access to the rest of the body. So we've got to do a whole body treatment instead of just treating at the prostate itself. Sometimes we don't know that until we take those lymph nodes out and we look at them under the microscope. So those are the ways that we think about prostate cancer. Say somebody has a low-grade prostate cancer, Gleason 3+3, 3+4, intermediate, or even 4+3, and they say, well, I think I want to watch this cancer. Because when we think about treatments, if you don't do anything, your lifestyle's great, you've got the anxiety of cancer, whereas if you do treatment, that has certain side effects with it. Trying to decide, like I said earlier, which cancers are lethal and which ones are just there and not really going to bother you, there's now genetic testing that we can do because there's a lot of genetic alterations in the cancer. But by looking at the genes of the cancer itself, there's two ways to look at genes in prostate cancer. You can look at the person's genes to see if they've got risk factors that are passed down through their family, or you can look at the cancer genes of themselves, because what cancer does is the cancer cells change their own genes. And when you look at those genes in the cancer, you can tell, well, this may be 3+4 disease, but the genetic signature makes it look like a very slow-growing, low malignant potential disease, so we can watch it. Whereas it may be a 3+3, but if we look at the genes and say, it's 3+3 today, but data's shown that with this genetic makeup of the tumor itself, in 4 or 5 years, it's going to be bad news, Gleason 5, Gleason 10 disease. We may want to treat this now so that we don't risk those things later in life. So doing genetics is sometimes what we do for low-grade or intermediate-grade prostate cancer to help us know what patients can we watch and what patients need treatment.
Mitch, I want to speed a little through because I want to definitely have some Q&A time here. And what can we do to help?
Yeah, so I put this in here because lifestyle is a big thing. So balanced diet. The most important study that's ever been done on prostate cancer was by the American Heart Association. And what they found is if you do a heart-healthy diet, it actually is a prostate cancer-healthy diet. And it decreases the risk of prostate cancer, and it decreases how much prostate cancer grows. That means eating diets and fruits and vegetables, whole grains, limiting red meat and fats. Exercise is another really important thing for prostate cancers. Independent studies have shown improved survival if patients spent 30 minutes of doing moderate exercise 3 to 5 days a week. They lived longer, irregardless of what treatment or what stage, than men that did not do exercise. And also stress management. We know that there's an immunologic response of cancers, and chronic stress, chronic illness can weaken the immune system, and that all has to do with mindfulness and stress management. So being thoughtful about those things in your life and having those support systems and that better emotional well-being can actually help protect during and before prostate cancer. So I'll just quickly touch on the treatments, and then I want to make sure we get plenty of time to answer questions. When we think about prostate cancer, there's 5 essential treatments. There's active surveillance. That doesn't mean do nothing. That means repeat biopsies, doing MRIs, things like that. And the idea is that we're going to watch the cancer, and if it starts to turn for the worse, we can still treat it and get cure. That is different from watchful waiting. Watchful waiting is a man that is diagnosed with prostate cancer and says, I'm good. I'm not going to come back and see the doctor, and they don't do anything until they have symptoms from the cancer, and it's too late to do anything. Active surveillance is an active treatment strategy, making sure that those low-grade cancers, we can still treat them. Hormone therapy. We know that prostate cancer uses male hormone testosterone as food. If we cut off its food supply, some of those cancer cells will die, others will shrink, but it will put the cancer in remission on average 3 years, sometimes longer, sometimes shorter. It's not a curative therapy, but it's more of a delaying tactic. And when you combine hormone therapy with radiation therapy, radiation's more effective in killing the prostate cancer cells. And then there's focal therapy. That's where I talked about, that's kind of that in-between where we say we're just going to treat that one lesion in the prostate and kill that one lesion because the prostate cancer is not in multiple places. So you have to be a good candidate for that. The idea is that you're doing more than active surveillance because you're actually killing the cancer, but you're not risking all the side effects of definitive treatment with radiation and surgery where you have to worry about incontinence, sexual dysfunction, radiation changes in the bladder or the bowel. The good news is at 10 years, 70% of those men are free from radical treatment. That means 70% don't need radiation or surgery. That doesn't mean they don't need another focal treatment, but they're not needing radical treatment. And then you get radiation and surgery. Radiation, you lay on a table 10 to 15 minutes a day for whatever they calculate the dose to be. It can either be with protons or photons, and I can go into more detail about that, versus surgery. Surgery is what I do every other day. I go in, I surgically remove the prostate and the lymph nodes, hook the bladder back up to the prostate. The goals for surgery are, number one, cure of the cancer, Number 2, preservation of the sphincter to keep men from leaking urine. And number 3, preservation of the neurovascular bundles that control erection. It doesn't do anything with sensation, feeling, or orgasm, but it does do something for erections. And so if you look at the data, the people that are good candidates for surgery are younger, healthier, and have a longer lifespan. At 10 years, whether you do surgery or radiation, the data has shown there's not much difference. But once you get to 15 or 20 years, men that do surgery do better than men that do surgery or do radiation or watchful waiting or ADT, just because of their lifespan, because you've actually removed that prostate. And so I just wanted to go over the treatments real briefly. We can go into more details about any of those, but I think it's a good idea to open up to questions.
Yeah, Mitch, so thanks for that. The reason why I had you come this year, because we've had a lot of prostate cancer around the church, and just seeing the community in general, I've just had more men come and say, hey, doc, what should I do for prostate cancer? So I definitely want to open the floor for questions about prostate cancer, or maybe people want to share experience they've had of going through the journey. So, Elder Baker.
Yeah, is there something related to females, like a female prostate, that this may be associated with?
No, so females don't have prostate. They have a gland, but it's a different gland, but they will never get prostate cancer. Now, I say that, but in today's generation, there's all kinds of pronouns and sexual assignments. So I will say I have had a patient that identified as a woman that had prostate cancer, and that was a first in my career in 25 years, but it can happen, but not naturally.
We had a question over here.
Hi, I'd like to know, my father was diagnosed when he was 73, he's 87 now. With an enlarged prostate. Mm-hmm. After begging, kicking, scratching, everything to get him to the doctor, he never was treated. So it's been 14 years now, and 3 years ago, I finally got the doctor to give him something to shrink the prostate. He was not diagnosed with cancer, mm-hmm. but as the advocate for my father, he is now on a catheter, because it's affecting his bladder.
Yeah.
What are some of the steps I can do to support him with the condition that he's going through? Because he doesn't like going to the doctor.
Yeah. So first of all, thank you for doing that, because as I'm reminded every day when I see my wife, if I didn't have people nicer and smarter than me, as men, we would fall apart. So thank God for the better half to help protect us from ourselves. So when we talk about BPH, that's different than the whole cancer conversation, right? So the prevalence of BPH is actually more than prostate cancer. So if you look at the studies, 80% of men, by the time they reach 80, will have BPH. As we grow older, our prostates or glands, they will continue to grow. That doesn't always mean that it's going to result in symptoms, but there is a higher chance the older we get. The problem is, as we grow older and we have these voiding complaints, we think, this is just part of getting older. I'm going to ignore this. The problem is men ignore it too long until it's too late, because the bladder itself is not very smart. It knows how to fill, hold, and squeeze. But if it starts not doing one of those jobs well, it causes havoc in our life. And so what happens is, as the bladder gets stronger and stronger to overcome the resistance of that prostate, at some point the bladder gets so strong that the body can't keep the muscles happy with blood and energy and those things. And so what happens is the body starts turning muscle into collagen. It's like spackle, because the energy requirements of muscle is much more than collagen. Once more of that bladder is collagen than muscle, it no longer has that elasticity and ability to squeeze. And that's when the catheters come into play. I don't know if that's the case, but that's what we call an end-stage bladder. There are things that can be done for BPH to shrink it through medications and other things, something called finasteride, Proscar, Avodart. There are medicines to shrink the prostate. There's also surgical therapies to manually shrink shrink the prostate to make it easier to pee. That doesn't have the same side effects as prostate cancer surgery. We remove the whole prostate. But if you think of the prostate like an orange, think of the outer part. That's the orange peel. That's where prostate cancer grows. That's why when we do a digital rectal exam, sometimes we can feel it. And then there's the meat of the orange, and you pee through the middle of that meat of the orange like peeing through a donut hole. So as the meat of the orange gets bigger, it obstructs the flow of urine, and there's things that we can do to remove the meat of the orange without doing anything to the orange peel. A lot of it just depends on how big the prostate is, the other risk factors, those things. So I would say that in your father's case, my recommendation would be to see a urologist to consider something to that prostate. And we now have minimally invasive surgeries where age is no longer an issue.
What are those symptoms that men are ignoring? They're waiting too late.
The symptoms that men are ignoring is when they go, they feel like they're not emptying completely. They're getting up multiple times at night to pee. They're dribbling more at the end of their stream. They're straining more to urinate. They feel like they're not emptying their bladder. The kidneys are starting to fail because the urine's backed up and they're never emptying their bladder. They're starting to get stones in the bladder or forming those things that we then have to go in and treat. So it can be a whole spectrum of different symptoms. But I'd say the best litmus test, you go to a sporting event, you go to a movie theater, you stand next to the 12-year-old next to you, you hear them hitting the back of the porcelain, you're barely clearing your shoes, and that's when you probably need to start thinking about something's not right.
I love it. Yes, Pastor Louis.
Can you talk about active surveillance in relationship to age? In other words, at what age would active surveillance be a good strategy?
So I actually think active surveillance can be a good strategy at any age, young or old. So a lot of it depends on the cancer itself, and a lot of it depends on lifestyle. So if you've got a whole bunch, if you've got, say, leukemia, diabetes, hypertension, you've had a kidney transplant, and you're on dialysis, and your overall life expectancy is 5 years, that prostate cancer is not going to get to you. But if you plan on, and we all do this, everybody plans, I'm going to be here for 10 more years. But if you're going to be here 10 years or more, then you need to start thinking about active surveillance may be good, but you need to be on top of it. Because, and I'd say if you're going to leave 20 years and you've got high-grade disease, active surveillance may not be the right issue. You may want to just treat and be cured. So the way I think about active surveillance is I think about it in terms of the cancer, and I think about it in terms of the patient. I don't use age as a requirement into that. I look, is this somebody that's healthy? Are they active? Were their parents long-lived? Do they plan on being around for 10 to 15 more years? Have they taken good care of themselves? I've had some patients come in and say, well, look, I just want 5 more years like I'm doing right now. I don't care what happens 10 years from now. I just got, I'm going to start taking up experimental aircraft piloting, and this is going to be my goal. High-risk behaviors, probably don't need to worry about prostate cancer. But if you're going to live for a long time and you got significant disease, then you need to pay attention to it.
So what do you mean when you say cured?
Yeah.
What does that mean?
So when I say cured, that means removing the prostate cancer so that it's no longer an issue in your life. So even with our best intent, when we do surgery or we do radiation, certain prostate cancers will come back. But there's a difference. If you do surgery and you remove that prostate and the PSA comes back in 3 months, that's a different disease than if you remove that prostate and that PSA comes back 5 years later. The longer the time goes between that prostate cancer coming back, the better it is in terms of that disease, the less risk that disease is going to end your life, and there's ways to control it. If you treat that prostate cancer and you've got a PSA that's detectable right after treatment, that means it's gone other places. And now you got to start thinking systemic therapy, hormone therapy, chemotherapy, immunotherapy. That's where we have to start using more tools out of the toolbox. And then the chances of cure are much less, and it's more about slowing the disease down. Does that make sense?
Yes. So if your Gleason score is like maybe 4 or 5, would that mean active surveillance would be a good strategy?
Typically not. If you've got a Gleason score with pattern 4 or pattern 5 in your prostate, those are high risk patterns. Those have a higher risk of spreading to other places and doing other things. So those were the ones where I probably wouldn't do an active surveillance treatment strategy. For those patients that have Gleason 3+3, 3+4, 4+3, I think active surveillance is good there. But if anybody's 4+4, 4+5, 5+5, that's bad disease.
So 3+3 and 3+4 is okay for active surveillance?
Yes, depending on the volume of disease. So we have some other criteria that we look at when we talk about active surveillance. This is getting into the weeds a little bit, but we look at what the volume of disease is. So if you did a biopsy and it was on every core of those biopsies, that means it's high volume. That's not a good one for active surveillance. But say you have one core that's positive and you took 12 biopsies, that may be a good one for active surveillance. Our criteria for active surveillance used to be no core more than 50% positive, not more than half of the cores positive for disease, PSA of less than 10, and the cancer localized to the prostate. Those were the candidates that we looked at for active surveillance.
Okay, thank you very much.
Yes, we have two.
Yeah, I just wanted to make sure, in regards to the prostate, removing the part of the cancer, is there a time when you remove the whole prostate?
So for the majority of surgery, standard of care is to remove the whole prostate.
Okay.
So the concepts have changed a little bit. And again, you guys are asking some great questions. We're getting into the weeds. So it used to be for kidney cancer, we would remove the whole kidney. Mm-hmm. Now we've learned we can just remove that part of the kidney that has the cancer and leave the rest of the kidney there. The difference in prostate cancer is it tends to be what we call a multifocal disease. So even though we see it right here on the prostate, it may be in other places. But with today's technology, with PSMA scanning, with MRIs, now we can identify what we call the index lesion, and we can destroy just that lesion. We can destroy it with microwaves, we can destroy it by freezing it, we can stick a laser in it and cook that part of the prostate, and now people are just surgically even removing just that part of the prostate. But historically and traditionally, we've moved the entire prostate, because even though you see it over here, there may be other disease in other places that we can't see. I would say in 2025, we're better at seeing more of the prostate.
Thank you for that, because that was, my dad over 20 years ago had his prostate removed. In the last year or so, his numbers in his PSA have skyrocketed, and that confuses me. If his prostate is gone, why are his numbers rising? What is that?
So that would tell me that there's probably some cells somewhere that are making the PSA and prostate cancer again. If it's been 20 years and it's caught, then generally the longer it's been from the time of surgery till that PSA comes back, then that typically means a local recurrence. So where that prostate was, maybe there were some cells there and it took this long for them to grow big enough to create PSA. And so you can radiate where that prostate used to be. You can do multimodality therapy. Sometimes when you take the prostate out and the PSA comes back 6 months later as positive, that means it's not a local recurrence. That means there's cells somewhere else in the body that are making that PSA. And so it's a difference between local disease and disease throughout the body.
Yes.
Once again, thank you for being here. I'm speaking as far as a female who's would be a concerned wife, concerned sister, as far as advocating for them, where I want to be able to, I'll use this as an example. My dad died of prostate cancer. There were 3 other brothers that died of prostate cancer. And so I have 3 brothers that I want to be able to pose a question to and ask them how to go to their doctors. I don't know if they have shared that family history, and then be able to ask the doctor, hey, since I'm hearing you saying there's some controversy about the PSA screening, how do you advocate and say, will that be automatically or will they need to ask for it? I guess that's what I'm asking.
It depends on their provider. But in that situation with that strong family history, I would say it's not a matter of even screening. That's where they need the PSA test. And so it needs to be, hey, I've got a family history of prostate cancer. You need to check my PSA. I don't care about the digital rectal exam, but I want that PSA test done because that's important. And it would almost be just as important for them to get genetic testing, not of the tumor, but genetic testing. Is there a gene that they're carrying? Because then that would indicate that, yeah, they're at risk for prostate cancer, which would be important for not just them, but their children, nephews, all of those kind of things. So I would say that's not a screening. With that positive family history, they need a PSA.
If I were a male, and I'm not, and my mom had breast cancer, passed away, and don't know anything about my father's history or his family, what age do you recommend I get an exam? So I know you said age 40?
In the 40s. Yep,
in the 40s?
Somewhere in the 40s. Doesn't have to be right at 40. I think that sweet spot's between 40 and 45. And I don't want to, but there is definitely a familiar genetic pattern of the BRCA genes. And so, but not everybody that has breast cancer is positive for the BRCA genes. But like I said, 10% of all prostate cancers are genetic where they're inherited. 90% aren't. That's why that family history is so important. And that's why if there's breast cancer in the family, getting that first value in the 40s, say 43, you get that PSA and it comes back as 0.4, we feel really good about that. We may not check another PSA for 3 years. If that PSA comes back at 1.2, I'm concerned. I'm going to check it the next year. If it comes back at 1.2, I'm okay with it. But if it goes up to, say, 1.6 in a year, that's that velocity curve. And see, these are the concepts that even healthcare providers struggle with. And so that's why it's important for people to have these conversations, to be aware so they can have their health in their best interest and go in and say, look, oh, it's still under 2. You don't need to worry about it. Well, that velocity means you do need to worry about it in your 40s, and you do need to get checked, because typically the prostate cancers that present in men that are younger tend to be the more lethal, the more aggressive, the faster growing prostate cancers. And so we have the best ability to affect prostate cancer and save men's lives at a younger stage. And nothing to say that we don't want to save everybody when they're 78, but saving a 45-year-old versus 78, there's a difference there in terms of life.
So, can you speak a little more about the connection to a family history of breast cancer? My mother died of breast cancer, and I have 2 sisters that had breast cancer. So I've been tested, the PSA test. They always come back in normal range, but the more I hear you say that, the more it gets my attention. So can you speak a little bit more?
Yeah. So there's 2 breast cancer genes. Well, there's actually more than 2, but there's 2 big ones that are associated with familiar and inherited breast cancer risk, the BRCA genes. So with that family history, I'm not sure if they've been tested for genetics. So generally when people present with cancer younger, we'll do that genetic testing, that germline testing. I think that is a miss in the healthcare industry. I don't think there's enough genetic testing done today. A lot of providers don't do that. But when you see that family history, you should be thinking, I wonder if we're carriers for that BRCA gene. And so some people may be carriers, which means you have it, but you never develop disease. You never develop breast cancer. You never develop prostate cancer. But it's important for your children, nephews, things like that, to know those things. And so if you have a strong family history of breast cancer, and they presented with breast cancer younger in life, I would say 60 or younger, having that genetic panel done may make sense in terms of that. And that's just a matter of pursuing it. Just because you have BRCA doesn't mean you're going to get prostate cancer, but it means you're at higher risk. Going back to that table of risk factors, you're at higher risk of potentially developing prostate cancer. So getting that PSA annually may be more important than saying getting that PSA once every 3 years.
Mitch, do you operate tomorrow?
Yeah, I have surgery tomorrow.
Okay. One more question.
That's okay. I'm
sure?
happy to make. I'm happy to. I'm late. I owe you time. I'm happy to sit here and answer as many questions as possible. No, I'm here for you all.
I have a question about testosterone. Does that have anything or effect on the PSA test as well as the prostate?
Yes, the answer is yes to both. So what we know is that prostate cancer is a hormonally responsive cancer. So the same way the medication, the hormone therapy works is by cutting off the testosterone, prostate cancers will shrink and die. What happens though is prostate cancers get smart. They say, well, if you're going to take away my food supply, the testosterone, I'm going to start making my own testosterone. And so actually cancer cells that are high dedifferentiated start making their own testosterone, something called autocrine, where they make their own food supply. So they ignore that. So testosterone will affect the receptors in the prostate and cause the prostate to grow. So it increases your risk of BPH, and it can also cause an elevated PSA because your prostate gets higher. But just because you're on supplemental testosterone for those men that have low testosterone and they need more because their body just isn't making it, just because you're on testosterone doesn't mean you're at an increased risk of getting prostate cancer itself. It's a more complex mechanism than that. So in other words, if you take away testosterone, that will shrink the cancer and hold it at bay. If you give extra testosterone, it doesn't necessarily mean you're going to at a higher risk of prostate cancer, but you are at a higher risk of elevated PSA and a bigger prostate, if that makes sense.
Dr. Allen, is there any questions on the chat?
I do
Any on
not
chat?
think we have any questions on the chat unless someone has anything.
Okay.
We do have someone that I'll be speaking to, Dr. Humphreys, that would like to talk to him. I want to just throw out that, Dr. Humphreys, thank you so much. You've actually made us aware. You've obviously educated us. You've talked about the screening, and you also shared information on advocacy. But one thing that I want to ask you quickly is research, because you said that in African American men, they're delayed. That's one of the rationales, but the other is because they're not involved in research. Could you enlighten us on that?
Yeah, I think that's a really great opportunity in the community. I think there's a lot of mistrust in the healthcare system, and with research, you think about different agendas. And I've heard every different thing. When we're doing research, though, what we're trying to do is not treat people like an experiment, but rather glean knowledge that will help them and other people. And so the big thing is when we open clinical trials, even at our institution, we have very little diversity in our trials because some men just don't want to be involved. They don't want to put in the time to come back and fill out the paperwork, to do the extra blood draw, to monitor their disease over the long term, because it is inconvenient. So it's a commitment, but it's a commitment that I think will inform and serve population, because what we know is that prostate cancer in Black populations is different than the other prostate cancers we see. And to get solutions to help in the Black population, we need individuals that are committed and willing to do the research to serve and help themselves and to help the community.
I also want to add that if involved in research, it also takes care of your medical bill in some cases, right?
In a lot of cases it does,
Yes,
absolutely.
I know.
Absolutely.
Okay, do we have any other questions? Oh, Dr. Logan.
Can you talk about prostate research?
Mm-hmm.
Some of the promising research that's being done to treat and identify prostate cancer?
So it's a great question. There's a whole bunch of different research studies out there. So some of the things happening right now that are relevant in prostate cancer research is I talked about the PSMA scan to find the prostate cancer. Well, now there's a smart bomb. So imagine that molecule that goes and attaches to the prostate cancer cell so that we can see it on imaging. Well, what if you added a little radioactive isotope to that carrier, so when that little molecule found the prostate cancer cell, it would radiate just that cancer cell and kill that cancer cell without treating the whole body with radiation. So one of those is called Plarify or lutetium, and that's out today. And so when the prostate cancer spread other places, the research has shown that it will go to those places where the cancer are, kill those cancer cells, and it's been shown to increase survival by up to a year in those men. That's just one example of research. But there's other elements of research that we're looking at for how does the immune system interact with prostate cancer, and can we ramp up a patient's own